Good evening. Welcome to Hot Topics. This is Dr. Arlan W, the chairman and founder of Activator Methods International. Tonight, we're going to discuss the caregiving and adjusting after a knee replacement. Now, I want you to know I'm a vitalist, except I'm an evidence-based vitalist. And never in my life did I ever think I would be having to deal with something like replacing a knee. But it's easy to be a vitalist, by the way, when you're 25, but when you're over 70, these things happen. And my wife, who was born and raised on a ranch in Arizona, had an accident when a horse fell on her when she was 14 years old. And she had a knee that got hurt at the time, but nobody paid any attention to it, just simply because it was, not enough of an injury at the time. Well, over the years, she developed more problems with it. And I have, for the last 20 years, kept her going. We'd have an occasional flare up and so forth. And we were at the Florida Chiropractic Association convention. And she went downstairs to go meet some people and came back to the room limping. As a matter of fact, she could hardly put weight on the knee. So I adjusted her and took some of the pain off and so forth. And actually, we went down, had it taped. But it continued, and when we got home, she was in severe pain. So we did an MRI, and when we took a look at the MRI, the radiologist said, you've got a real problem here. There's no cartilage, and your wife has been flat-footed, and therefore she, had knock knees, if you want to call it that. And so all the weight went on the outer part of the meniscus, or the lateral meniscus. And she just simply wore it out. And he said the femur is actually grinding on the tibia. And so as soon as you can, you're going to have that knee replaced. So we started the process. And so that's what I thought we'd talk about tonight, because I guess it was a 3-month learning experience for me is the best way to put it. It was things that I had no idea how to do before. I'm going to take you through the medical part first. Then I'm going to take you through what I learned chiropractically, because as we have this aging population, number one, we're situated in Activator, and the 400 people on the topic here tonight are, if you're not an Activator, this will give you an idea how Activator can help you. But let's start out, and we'll look at a few of the things here that we have, difficulties with, and what you want to look for and so forth. And so let's start with the surgeon. Now, because it's my wife and I love her, I'm not going to go have somebody that's cutting meat at a local supermarket do the replacement. And so we started looking around the city of Phoenix and found out that Phoenix is the knee and hip replacement capital of the world, because we have a big geriatric population. And so we interviewed several different surgeons, and we interviewed several patients. And what I really recommend you do is find a couple of people that have had it done, and then let them tell you what the results were. And I'll tell you in the end here another way to tell who you should have as the surgeon. But the surgeons that we talked to all had different ways of doing it, but the one that impressed me the most was the surgeon said, we'll operate at 7 a.m. in the morning, and you'll be walking around by afternoon. Now I thought, boy, this is a guy for me. If it's that quick, well, there were some things he left out a bit, but let's move on to the next one. Here's what he said. We do not cut any muscles anymore. And what they actually do is they take the patella and they pull it off to the side. And just to give you an idea how the medical world has improved, when she had her MRI, they then constructed a knee to the exact size and shape and everything that a new knee would be, as she would require it at this time in her life. So they took the MRI, made a new knee for her, and then they said the reason rehab will be easier is simply because we don't cut the muscles. And you can imagine if you cut all the leg muscles, you'd have to have all of those rehabbed also, but this was a selling point. So that's where we went. And all of that's true. There's just one problem they forget to emphasize. then when you will have 3 months of rehabilitation. And I'm happy to report to you, my wife just got released from rehab here yesterday, and she's doing well. But let's start from the beginning, and we'll just move along and show you some of the things that you want to be prepared for in case you are contemplating a knee replacement, or if you have patients that come in and say, should I have a knee replacement, and what to advise them on and what to expect. So that's kind of what this is about tonight. Now, the Phoenix surgeon we used was Dr. Brandon Gow, and he's from the Headley group here in Phoenix. He's a renowned surgeon. There's 2 surgeons in town that we like. Dr. Gow was one of them, and Dr. Chow. There were 2 of them here that we decided which we're going to do, and Dr. Gow was the one we decided. Now, this was way back in August, the end of August, when we were at FCA. And so we went in, did all the preliminary works and everything. And so I thought, can't be too long before. Well, he said, I have a 90-day waiting list, but he said, because you're a professional, he said, we'll put you in the first cancellation. And he said, there's always people canceling. So he said, just stand by, don't be out of town because, and I said, you don't have to worry about that. She's not going anyplace. And so, but here's the funny part. We waited 90 full days. It was actually November 29th before that was when her appointment was, and that's when she finally got in, because when people are in that much pain, believe me, they don't want to cancel. So we didn't have the first cancellation. We had the date that he assigned to us. Now, when we went and interviewed the doctors of physical therapy for rehab, they were relieved, as he was one of the ones that they loved to work with. And I went over to the rehab place and I interviewed him myself and told him who I was and told him that I wanted to find out what they knew about it. And the place that we finally decided on was Foothill Rehab, and they were close to us here in Chandler, Arizona, like 5 minutes from our house. And they were just a great place to go. And we'll talk about that in just a little bit. Now, here's some tips and items required as a patient or a caretaker. And some of these things you don't think about. Ice. Boy, was I happy to have an ice maker in my bar in my house, because that thing got used like you can't believe. And when we got her home, and by the way, she only stayed overnight, and the next day she was back home, ice and a lot of it. 20 minutes on, 20 minutes off. And we did this, or I did it, around the clock if you really want to keep the swelling down. And the surgeon was just blown away after, for post-op, when he saw that there was no swelling and there was no black and blue. He said, what did you do to keep it from doing that? And I said, well, we just took real good care and iced it. And we kept a lot of ice. Now, here's something. You just don't think about this, but the number one problem is the patient cannot get off the toilet because you have no ability from the knee to do it. There's no strength. So a booster seat for the toilet is an absolute must. This will be one of the most important pieces of equipment during the first month. And you have to really pay attention here, because if the caretaker, which was me, and I weigh 190 pounds, and my wife weighs considerably less than that. So I had no problem, holding onto her and pulling her up off the bathroom seat. And so, but a booster seat we finally got, and that was a blessing in disguise, because it's just the height, and so she could come almost straight off. And in hospitals, you'll notice they always have these, like, somebody that has to have a higher toilet seat, a disabled person. And they have another little thing. They have bars on the side that the patient can grab onto. Well, when you get home, there's no bars. The toilets are lower. And so if you have a patient come in, you tell them, here's a couple of things that you want to get. Number one is a booster seat for the toilet, because it's just incredibly hard to get up and off the toilet seat. And the other thing is, if it's the man of a couple, you want to be sure that, if he weighs 250 pounds and his wife weighs 90, it's not going to work. Now, another good friend of mine, he had the knee surgery, and she said, there's no way that I can can help him off the toilet seat. And he ended up going into assisted living for a period of 3 weeks. So he was able to get up off the toilet himself. So these are just a couple of things that I never even thought about. I mean, I've never been exposed to this kind of thing before, but just be sure that the caretaker is strong enough, bigger than the patient. Now, here's some tips. I know you think as chiropractors you'll never take any narcotics or any kind of drugs. Well, I got some news for you. My wife said the same thing. I'm not taking any oxycodone. I might take some Tylenol. And I'll tell you, the first day that by the way, she got out of surgery on Thursday, was home for the weekend and started rehab on a Monday morning. And she took the oxycodone very gladly, because when they start bending that knee to get flexion back into it, I will guarantee you will take something to keep that pain down. So it knocks out all the reflexes. And so when I'm trying to help her, and I thought, well, I can adjust her now. Well, I couldn't, because there were no reflexes, so I couldn't do a leg check. And so it was a totally different way of treating a patient. Also, the oxycodone will constipate the patient. So have a good laxative handy. And my good friend, who's a cardiovascular surgeon here in my compound, he said, use magnesium citrate in a liquid form. And boy, was he right. A half a bottle of magnesium citrate and the constipation was gone. But I'll guarantee you, my wife said, be sure we have some on hand, because it was the only thing that helped move the bowels. Now, also the patient will have to take aspirin to avoid blood clots, because in a knee surgery, one of the most dangerous things is a blood clot. And the surgeons will tell you right away, you will be taking aspirin, for at least a week before you start into the surgery, and you'll be taking it all during the time of rehab and so forth. And so she avoided all blood clots and so forth, but she was very careful. We set a little chart up, or she did, because she's very organized, on the time to take the medication, the time and how many, and what time during the day. So she had a chart all built, and then she checked it off when she took her different types of medication. Next, the patient will have muscle spasm. Now, I'm not talking about little spasms you get up and walk out. They are real spasms. And again, because I am a DC, I was able to work the spasms out. And the MD also gave my wife a muscle relaxant, which she didn't want to take it either. Well, one muscle spasm, and I'll guarantee you she was on a muscle relaxer. So these are just some of the practical facts that take place when somebody has that kind of a major surgery. Remember, they're taking a whole part of the femur out and a whole part of the tibia out. It's a major surgery. Now, be sure to have some kind of a wedge to place under the patient's legs or pillows to raise them to reverse the gravity and drain fluid. We were very, very careful not to let that fluid accumulate at all. And so we were very happy to have the wedge. And another friend of mine brought the actual wedge over for me. He'd used it for his wife who'd had surgery one time. And he brought it over, and he said, you're going to need this. And boy, it was about a week after she had it, and she was propping it up on pillows. But she used it, and she was very happy to have it, because it drained the fluid, and we just didn't let her get into trouble. And I think that was probably why she didn't have any trouble with blood clots and so forth. Now, the hospital will furnish compression socks, which are absolutely necessary. They will put those on as soon as they have the surgery, and they have these compression socks. Then they have another one that they put around, and they actually air pumps through them, and it compresses the leg and lets it go, and compresses it and lets it go. Then they'll send you home with compression socks, and the patient will be very happy to wear this because they feel good. And so just be sure that you absolutely use the compression socks. Now let's talk rehab. This is the part that I had no idea what we're going to get into. I interviewed several of those DPs, and we ended up with one that was we absolutely came to love. She had got her DPT 17 years ago, and she was like 43 years old, so she was a young girl. but she was just great with patients. And the big thing that impressed her was that, my wife kept pushing the limits, and she was tough. And she'd say, if you want your full flexion and your full extension, it's going to hurt. And she said, she complimented my wife because she was always willing to push the mark. And that's her nature. She's going to go for a goal, and boy, she's not going to have 1 degree of lack of flexion or 1 degree of lack of extension. And so her and this PT got along just extremely well. And she just, as I said, got released, just 2 days ago from her rehab. And she has complete flexion and complete extension. And you would not know that she is now a bionic woman. Insurance, you want to take a look at this because, boy, this stuff is expensive. I went into Headley Orthopedics and I said, beside Medicare, here's our supplement and here's our drug coverage plan and so forth. And to date, we have not had any out-of-pocket expenses. Now, I've heard some horror stories when I was over at rehab for some of the people that, one, they didn't have any supplement, and Medicare only covers about 80% of it. So you could be looking at $20,000 on just the supplement coverage that's not there. So I recommend highly that before you start the surgery, go into the office and go to the business office and tell them to take your insurance in and so forth and make sure that it's going to be covered. What I learned from the chiropractic standpoint, you're going to find this most interesting. Number 1, oxycodone knocks out the reflex system. Tylenol does not. And I learned this back years ago. I remember one night I was practicing from 7 to 9 at night, and the guy came in and he was pretty intoxicated, and I knew him, and he'd been a patient for a long time. And he said, I've been having a few beers, but I just want to make sure you could check me. And I checked him, and it wasn't a problem. The reflexes were fine. I thought, wow, that's interesting. And then I had somebody come in one time that was on a drug, and it was actually a young woman, and she was on a tranquilizer, and the reflexes were flat dead. And so I was like, oh my gosh, I started keeping records on this. But boy, it was surely true here. The oxycodone knocked out the reflex system. The Tylenol, by the way, they use Tylenol. That's the next step after the week or 2 of oxycodone. Tylenol does not. Now, after the reflexes came back and the learning began, remember that when you put a complete new knee in, it will change the patient's gait. Her gait was adaptive. And by the way, we knew that she was having some hip trouble also. So the PT, when she started this, she said, let's do the hip along with the knee. So she did the hip along with the knee, and she's having absolutely no knee pain now too. So the pressure's back where it should be, and I think it saved her hip. I was confused at first because the PD leg went short and got shorter when I finally got her so I could do a full flexion. So where do you go when a PD leg goes short and gets shorter? That's an indication of going to L4 on the opposite side. So I immediately looked for a 4th lumbar on the opposite side, went over there and pressure tested that L4, nothing. It didn't make a difference. Now I'm really confused. I'm thinking, well, that's always the way it works, so I'm going to have to look for something else. So when it didn't balance the legs, I started hunting. And here's what I learned. Guess what it was? It was an inferior pubic bone on the side opposite pelvic deficiency. Remember, the gait changes. Well, when the gait changes, the pelvis changes, and her pubes got locked up, and so she had an inferior pubic bone. When I adjusted that inferior pubic bone, it was total relief for her. By the way, she went back to the PTs, and they said, my gosh, I guess we should have a chiropractor over here. And as I saw the number of people that they put through there, it would be a perfect multidisciplinary thing for a chiropractor. 3 months later, we were still having to occasionally adjust the inferior pube, but not as much. Then came my next learning experience. The gait change caused another change in the pelvis. The pubic bone settled down, but guess what? The PD leg still shortened, and I looked for an inferior pube on the opposite side, but she had a new development. And if you remember last year in our clinical topics, our advanced classes, there was one of our field doctors out there that discovered that the sacrum can go anterior, inferior, and it can go posterior, inferior. And sometimes when the pelvis, or the leg, the PD leg goes short and gets shorter, it's a anterior sacrum. So I looked and she developed this anterior sacrum, and she received a posterior adjustment on the third sacral tubercle, and it worked miracles. I mean, her gait went back, and she had to learn to walk heel to toe, and without pain. But I mean, it wasn't a day before it went back. She got off the table, and it was instantaneous. So I had, I'm keeping notes on all this, and that's when I decided for Hot Topics, let's do this, because I'm sure there are people out there that may be considering getting a knee replacement themselves. By the way, one of my chiropractors here in Phoenix, one of our Activator doctors, had a knee replaced, and he was a great help to us because he told us some things to expect and so forth. And it was really wonderful to have somebody that had the experience. That's why I decided to do this. So the patient has to learn, as I said, from heel to toe all over again. It's a brand new experience of walking again. And it's also, the patient will have cellulite type bumps in the calves of the legs. Now, you know what those stick rollers are? Well, that's what I use to relieve them. I just roll the stick roller up and on the bumps of the calves, and it would feel good to her, but it was awfully sore. So you just have to be careful about how much force you're using on it. Well, I'm happy to report today, as I said, that my wife has no pain. She's got complete extension flexion of her knee and is back in full form. And so I just thought that I would bring this to you tonight so you could find out what my experience was. And if you have any questions, please feel free to get on the chat room and ask any questions that you have. And we'll wait a few minutes, and I'll be glad to answer anything that you have. The other thing too is I just want to go back and remind you again that many times you can keep people from having knee surgery for many years. As I said, it was 20 years that we knew she had some knee trouble, and we knew that she was. Oh, here's a good question that just popped up. Dr. Fitzpatrick just asked, did you use laser prior to or after the surgery? And the answer is yes. I don't know how I forgot that. I have a Metagenics laser, and yes, I did. And I used it after the surgery, and it took the swelling out. And the interesting thing, the swelling came underneath the knee. And so that was where the laser worked out so well. We used it there, and then we used it on the muscle spasms. And so it was very helpful. And here's another from Ashley, Maryland. She says, thank you. I've treated several patients with knee replacements in the last 6 months. Did you use any laser? She asked the same question in varied settings based on where they are during the recovery. If you contact Max Konarski at Multiradiance, they have a brand new complete setup for knee replacement or any surgery like that. And he shared that with me, and I just followed his settings, and he can send that to you. You just contact Multiradiance, and they'll give you the settings for the laser. But yes, I highly recommend the laser on it also. If there's anybody else that's got a question, yes, here's another one. If someone had 2 knee replacements within 6 months duration, what is a good approach to restore the gait? Well, here's the interesting thing. People, because now we have been around knee replacement people, when you do something yourself, then you learn all the things that people want. And here's what the surgeons have a tendency to do. They'll do one, and now, for example, my wife was November 29th, and now it's March, and she's recovered. And she just said the other day, I have a little pain in my left knee. And I said, so what are you saying? And she says, well, do you think we have to have that left one done? And I said, well, why don't we go through the same procedure, MRI it, see what they say. But a lot of people, because they've had such bad knees all their life, they will do just that. They'll have one done and it feels so darn good, they'll have number two. And so I would say that you're going to get one done. You want to get the one back in good shape and then start, asking about another one. But you said, what are some of the laser things here? And I'd say that just ask multi-radians for the laser settings. And what's a good approach to restore the gait? Well, number one is you got to get the pelvis lined up. Just as I got done explaining here, you're going to have some things like you got to go according to the patient, because the patient's going to have different things. And it was the thing that surprised me the most is how it went from that left inferior pubic bone, and then it popped over to the anterior sacrum, and it was just a total change. And I happened to just fool around till I found it. Is really what it amounted to. When I found it, the results were just immediate. They were excellent. So here's one from all the way from Australia, and it says, in your investigations, did anyone suggest stem cell treatment? Yes, as a matter of fact, they did. The surgeon that we went to, we asked him about stem cell because I had another friend that had stem cell, and he said, no, this one's too far gone. Because we thought, man, if the stem cell worked, we would go that route for sure. But when it was so damaged and it was the femur, grinding right on the tibia, it just wouldn't allow for that. Now here's another one. Good evening, Dr. Fuhr. Thanks for sharing with us. Can you check the leg checks from the PSIS and get the same results for a leg check? And is it okay to adjust the medial and lateral knee joint spaces when performing the adjustment for possibility one? Well, number one, that we don't adjust the meniscus and so forth when we're adjusting the knee. We're actually adjusting the medial, lateral, collateral ligaments and whatever is going wrong in those. Now, here's the interesting thing. I checked the medial and lateral, collateral ligaments, and guess what? There was nothing there. And there still hasn't been anything there. The knee is working just fine. It's in the pelvis. And I said, I want to be damn sure that I end up with a level leg lengths. And the surgeon laughed. And he said, in the old days, he said the people didn't pay any attention to leg length inequality. And he said, boy, I'm going to tell you today we do, because we got it down to a millimeter. And so that's the kind of surgeon that you want to get that takes all these things in. Well, I hope you have enjoyed this tonight and have something to think about. And, if you want to ask any questions you think about afterwards, you've got my email, and you can email me at awfuhr@activator.com, and I'll give you any experience that I have with it. And I hope you had a good time tonight. And I like to keep these short and informative. And so I want to thank you for taking your time. And for those of you that didn't get it live, you can get it on the internet because we'll post it. And so again, thank you for your time, and we'll be looking forward to next month's hot topic.